Welcome to Wellness and Wisdom with me, Dr. Nadu Tuakli. Here you can expect to hear conversations about everything women over 40 care about. From optimal wellness and peak performance, from intimacy to travel and finances and more. I will be speaking to interesting women and sometimes men to educate and motivate you to live your best life. If you want to find out more, please head over to my website, drtuakli.com, or subscribe to my blog. You can also read my book, Sex, Sanity, and Sleep. We are in this together. Welcome back to Wellness and Wisdom with me, Dr. Nadu Tuakli. Today, we're going to be talking about a class of anti-obesity drugs called the GLP-1 agonists. And these seem to have taken the world by storm. Collectively, they are medications that were originally designed to improve diabetes, but more and more they are being used for weight loss. And now they are touted to prevent heart disease and all kinds of other medical conditions. The most famous one is Ozempic. In some ways, this word has become synonymous with these drugs, just as people use the term vacuum cleaner, they talk about Hoovers, or a copier as a Xerox, but there are actually many other brands. But all these medicines make you lose weight, and we are going to talk about how much and how fast. Other members of the class include other semaglutides like Rybelsus and Wegovy, in addition to Ozempic. And there is another class called tirzepatide, whose brand names are Mounjaro and Zepbound. So I, like many people, for ease of use, may refer to semaglutide or Ozempic as an example of the class in general, but I'm not trying to advertise any particular brand. It is currently estimated that 30 million people will be taking this class of drugs by 2030, which would be about 9% of the US population. These medications are in a group of the top 5 highest grossing medications of all time, including Viagra. US healthcare providers wrote more than 9 million prescriptions for this class of drugs for weight loss during the last 3 months of 2022 alone. I'm not going to bore you with a bunch of statistics that you already know, such as that 1 in every 3 person in the US is obese, and that number is expected to go to 1 in 2 by 2030. You can read up on all that stuff, but what we want to know today is, number 1, are these drugs safe? How long do you have to stay on them? How much do they cost? Is this just the latest convenience weight loss fad, or will it end up being another fen disaster? And what does successful weight loss look like? And how can you achieve this with these medications? And most importantly, how do you maintain it? So, without further ado, let's get into it. My guest today is Dr. Tamer Yaqub, a board-certified endocrinologist, and he's also board-certified in obesity medicine. He has been in private practice for the past 26 years with special interest in diabetes and obesity management. He has been involved in multiple clinical trials in the diabetes and obesity field. And disclaimer, he does consult and speak to doctors on behalf of multiple pharmaceutical companies, including Eli Lilly and Novo Nordisk, the makers of the Ozempic. So welcome to my podcast, Dr. Yaqub.
Oh, thank you very much for having me.
And thank you for being here. We appreciate your knowledge and your insight on this very hot topic. Would you like to make a comment about the incidence of obesity?
You are spot on. So 1 out of 3 people in the United States have obesity, and unfortunately, this number is expected to rise. It will be 50% of the adult population will be obese by the year 2030. So you can imagine that the burden of the disease is huge from a health standpoint and also from a public health standpoint. Because as you know, with obesity, it's not only a few pounds. With obesity comes multiple problems. We usually like to classify it into the 4M. First M is metabolic, which is diabetes, prediabetes, hypertension, high cholesterol, fatty liver disease. The second M is mental. With the extra weight, there is a lot of mental illness, mainly depression and anxiety. Actually, 1/3 of the patients who come to see me at our weight loss clinic they suffer from anxiety and depression. And that could be the trigger for the obesity, or the obesity could be the cause for the anxiety and depression. So they kind of go hand in hand. The third M is mechanical, which is the extra weight that adds more pressure on the body. And starting from head to toe, it can increase the risk of obstructive sleep apnea, reflux disease, joint disease, and inflammation and chronic pain. And the last one, which we still have a long way to discover, is the malignancy. So obesity has been associated with increased risk of certain kind of cancer. And despite the fact that we have very powerful medication to fight cancer, but there are 13 different kinds of cancer that are associated with obesity. And unfortunately, they are on the rise. They are not coming down. Those are usually breast cancer, uterine cancer, prostate cancer in men, and all of the cancers in the digestive tract, esophageal, colon, and stomach cancer. So you can see that it's not only a few pounds, or I cannot fit in, the right suit or the right dress. They're definitely
cosmetic,
much more deeper issues associated with the weight gain.
So we know that there are modifiable risk factors that are contributing to the obesity, which, as you said, sometimes you're left with, is this the chicken or is it the egg? What's the cause and what's the outcome of it? But obviously we know that the modifiable risk factors include diabetes, hypertension, and high cholesterol, lack of activity, poor nutrition, and smoking. But by the same token, reducing the obesity will improve some of these other factors, right?
Very true.
So these conditions improve with weight loss, is my understanding. So how much body fat needs to be lost to be able to improve some of these conditions, like hypertension?
So most of the data we have is with body loss, not necessarily with body fat. So in order to decipher, you will need to have what's called a body composition scan, which is not really available on a wider scale. And most of the clinical trial, they looked at the whole body weight, not necessarily the total body fat. But your point is very well taken, that losing fat is more important than losing weight, because when you lose weight, you lose both muscle and fat. But generally speaking, as little as 3 to 5% will improve your diabetes control. Between 5 to 10%, you get more improvement of the blood sugar control. You get improvement of the blood pressure. You get improvement of the fat concentration in the body, what's called triglyceride. It goes down, and the good cholesterol, HDL, it goes up. Once you get to the 10% mark, you start to get the mechanical benefit of the weight loss. For example, in the case of obstructive sleep apnea, if you lose 10% of your weight, your apnea score drops by 50%. There's something called apnea-hypopnea index, or AHI. That drops by 50%. So if you have
50%.
Correct. So if you have mild to moderate sleep apnea, it actually goes away if you lose 10%. If you have severe sleep apnea, it doesn't go away, but it improves to the point that you can actually use less pressure on your CPAP device. So it will make it more tolerable, because a lot of our patients cannot tolerate the CPAP, especially if they are using a very high positive pressure. And anything above 10%, I like to call it the bonus round. So anything above 10% is a huge success. So a lot of our patients, they come and they say, I would like to get back to my high school weight. That is wonderful. But realistically speaking, sometimes that's a little bit unrealistic. So we usually do not go by an absolute weight loss that you need to lose 20 pounds or 30 pounds or 50 pounds. We usually go by percentage. And we celebrate every time they hit one of those landmarks. So we usually set a goal for about, between 10 to 15%. So once they hit the 5% mark, we usually celebrate that. And we usually send a note to the referring physician and tell them we're very happy that the patient lost 5%, the blood sugar, the cholesterol has already improved. And when they get to the 10%, so we actually have a standardized letter in our office. We call it the 5% letter, the 10% letter, and the 15% letter. And the 15% letter, on the background, there are stars all over the place.
I know you have a multidisciplinary approach for the management of obesity, and I would love to have you come back another day and actually talk about the whole approach to the management of obesity. Go ahead and tell us maybe the 7 risk factors and how the plan works. And then we'll start talking about what my main goal today, which is the focus on the pharmacological therapy.
Excellent. So I will be very brief. So the 7 that you have already mentioned are the diabetes, the blood pressure, the cholesterol, the obesity, the lack of physical activity, the poor nutrition, and the smoking. So each one of them would increase the future risk of heart attack and stroke. What we need to do is to modify every single one of them. The other one that we cannot touch, obviously, is the age. We cannot really modify that. Like any kind of chronic disease management, there has to be some kind of a game plan. And I like to call it the four-legged chair. If you break one leg, you get by. If you break two legs, we're not going anywhere. The four legs of the chair are meal plan, not a diet. We don't use the word diet because diet is something you do for a short period of time, few weeks, few months, and eventually you will get back to your eating habits prior to that, and that's usually not the very best thing. Second thing is activity, not necessarily exercise, because not everybody can exercise. A lot of our patients who have chronic back pain or knee pain or hip pain, there are tons of activity that they can do without aggravating their underlying problem. Number three, behavior therapy, or we call it cognitive behavior therapy. And that is actually the most important one. That is the glue that keeps everything together. And we usually ask our patients to do two things. Number one, keep track of what they do. And number two, prepare everything like in advance. For example, their meal plan, they will need to do their food shopping once a week, which we all do, and prepare the food in advance. And when they go out to their work, they will take the food with them. So they will have 100% control of what they eat rather than going to the most convenient location that might not have the best choice. People who keep track or they keep a record of their food intake, they do much better than people who do not keep a journal. And the journal is very helpful because during their weight loss journey, they will look back at the weeks when they lost 3 or 4 pounds and they see what they did. And they also look back at the bad weeks when they gained 2 or 3 pounds and they see what they did. And they learn from their own lesson. And the best part is it is written in their own handwriting. So basically, this is what you did and this is the reward. This is what you did not do. And this is, the lack of good results. And last but not least is the medication. So if you actually follow some kind of a meal plan, and there is no perfect meal plan, everybody have different preference. So whatever you can stick with is great. Physical activity, if I can just add a couple of seconds, you basically would like to combine both cardiovascular and resistance. So cardiovascular, anything that will increase your heart rate, and resistance, anything that you do have some kind of resistance. And our favorite resistant exercise is stretch bands. You can actually buy it for $20. It's very affordable. They come in low, medium, and high resistance, and you start with the low resistance as little as 5 minutes, 3 times a week, and slowly go up as you build your tolerance and your stamina. And the nice thing about people who do resistance training that they minimize on the muscle loss. Muscle is really important. When you lose weight, you don't want to lose muscle because muscle regulates your metabolism. So if you maintain a muscle mass, you keep your metabolism up. And that's not necessarily very helpful for the weight loss, but that's extremely essential for the weight maintenance so you do not gain the weight. And I think we're going to talk about that in more details. Last but not least, medication. In the obesity space, the medication is still kind of very early on because we have very limited number. To give you an example, in treatment of diabetes, we have 13 different classes of medication. In the obesity space, we have 5 medications. And if you think about it, we have 30 million people with type 2 diabetes, but we have 100 million people with obesity. So clearly, the medical therapy is going to advance. And on a positive note, there are over 60 to 70 compounds that are actually being investigated as we speak for weight loss. I'm not sure that, how many of them will see the day of light, but the good news is there is a lot of potential of very powerful medication down the road. One thing that I would like to add is one of the weight loss medication that is already available and approved on the market has been recently granted indication by the FDA, not only for weight loss, but also to lower the risk of heart disease down the road. And we're going to cover that in more details. So basically, the four-legged approach is meal plan, exercise, behavior, and medication.
So, it's interesting to me when you mentioned the food log, the food journal. That seems like a really easy thing to do. But I can tell you, it's not easy to get your patients to keep a journal. I mean, every time I say to a patient, I want you to write down what you're eating every day, and it's critical to, before you put it in your mouth, you write it down, because otherwise you're going to forget. And they just roll their eyes, and every time they come in, have you brought your food log? And like, oh no, I forgot. So it's actually harder than it sounds.
Part of the behavior modification, it is not fun. But, you can actually do a couple of things. So we actually have our own food journal, and, it is actually divided in all the things we ask them to: their food intake, their water intake, how many hours do they sleep. So we have picture of cups. So every time you have a cup of water, you just do the check mark. And, for their food intake, we usually broke it down into breakfast, mid-morning snack, lunch, mid-afternoon snack, dinner, and late night snack. So I usually tell them, just keep it by your bedside and keep a pen handy. And we usually give them our pen with our phone number and the website. So, it's a constant reminder because it's next to their bed. And before they go to sleep, they write it down. And we actually ask them, how long does it take for you to fill the food log? And the answer is between 1 to 2 minutes. For those people who are tech savvy, there are multiple apps that they can actually have a digital log. But we usually ask them, how long does it take you to put the digital log? And it takes 3 to 4 minutes. So believe it or not, actually writing it down the old-fashioned way.
The good old-fashioned way.
Yes, it
always
takes
the
less
best
time. And as I mentioned earlier, it will be actually theirs forever, because when they lose their phone or when they drop their phone in the water, they lose their log. But when they have a physical log, you can look at it and you see your good weeks versus your bad weeks.
I can see that you are from my decade.
Yes, we think alike. Exactly.
I love the good old-fashioned ways. You have the paper, you can't complain. So today we're going to focus on the pharmacological therapy aspect, simply because most people are curious about the new class of drugs, and they've often tried a lot of the other modalities that we mentioned. So first of all, how do the GLP-1 medications work?
All right. So first, as you mentioned, they were discovered mainly for treatment of diabetes. So they are very smart medication. And by smart, meaning that they kind of release two hormones on demand. One called insulin to lower the blood sugar, and one called glucagon to protect from low blood sugar. So when your sugar is high, you have more insulin and very little glucagon. And as the blood sugar returns back to normal, the insulin signal is suppressed, so you do not release any more insulin, and the glucagon level goes up. So this way you maintain the blood sugar, and chances of low blood sugar reaction happen to be zero. As we started to follow those patients with the diabetes, we found that they actually have decreased appetite and their weight is coming down. So they decided, okay, let's look at other possibility of how those medications help to lose the weight. So they found that those medications work on a receptor called the GLP-1, which stands for glucagon-like peptide. You don't have to remember that, but the GLP-1. So those GLP-1 receptor happen to be present in the brain in a place called the hypothalamus, which is the center in the brain that regulates hunger and satiety. So they found that those medication, they manage to cross through the brain and stimulate the satiety center. So you get that sense of satiety. And the first thing that we notice from our patient, they say that, as I'm taking this medicine, I notice that I am not as hungry. And I used to go for a second portion after I finish my dinner because I'm starving, but now I'm very happy and satisfied with that. And I do not feel the need to constantly snack in between meals. And this is how they lose the weight. So the first generation of those medicine used to be called exenatide or Byetta, that was discovered in 2006. But it was the very first medicine, and it has a very short duration of action, so you really have to take it twice daily. Ideally, it should have been given 3 times a day, but that would have been impossible for the patient to follow, so it was twice a day. And we had some fantastic results as far as improvement in the blood sugar, as well as the weight loss. And then the second generation came along called liraglutide or Victoza, which was an improvement from the Byetta because it was only a once-a-day injection, which is obviously a huge improvement compared to the twice a day. And same thing, the blood sugar improvement was even better, and the weight loss and the appetite regulation was even better. And then came the third generation, which is the once-a-week medication. And those were, again, developed for treatment of diabetes. One called Trulicity, and the Ozempic, and the Mounjaro. And those 3 have a very long duration of action, and it can be given once a week. And with the third generation of the GLP-1, we found that there was more improvement of the blood sugar, no risk of low blood sugar reaction, and the weight loss. And this is when we decided that it is time to use those medications beyond the diabetes, and let's just look at the effect on the weight. So that will be offered for both people with and without diabetes. So the first one that was developed for weight loss is the same compound of the semaglutide, which is the Ozempic, but now it's available in a different format called Wegovy, in a different dosing. So the dose for the Ozempic for the treatment of diabetes is 0.5 milligram, 1 milligram, and 2 milligram weekly. The dose for the Wegovy is 0.5, 1, 1.7, and 2.4. So 1.7 and 2.4 are the two highest doses, and those are the two doses that is recommended for maintenance of weight loss and weight maintenance. So those are like the long-term treatment. And March of this year, March 2024, there was a study called the SELECT study. SELECT study is the very first study to show that a weight loss medicine is going to lower your risk for heart attack and stroke. So they looked at people with high risk for heart attack and stroke, and they put half of them on the Wegovy 1.7 to 2.4 and the other half on what's called placebo or the fake medicine. Everybody was counseled about healthy lifestyle, eating right, and exercise. And at the end of the study, they tallied the number of heart attack and stroke and death from heart attack and stroke, and it was down by 20%. So this is something huge. So we're not talking about obesity treatment. We're talking about health-wise as well. So not only you are losing the weight, but if you are at a high risk for heart attack and stroke and you go on those medicine, you get an added bonus of lowering your future risk of heart attack and stroke and dying from heart attack and stroke by 20%. And then the latest addition was the tirzepatide that you mentioned earlier. Now it's available in two forms, one called Mounjaro for treatment of diabetes and one called Zepbound for treatment of obesity. And Zepbound was approved in November 2023. So it's less than 6 months old. And it also showed fantastic results as far as the weight loss. However, because it's relatively new, so the studies on heart attack and stroke are not complete yet. It is ongoing, but it will not be completed until the end of 2025.
So how is tirzepatide different from semaglutide, or is there a significant difference? And what about retatrutide?
Okay.
Is there a difference? Is one better than the other?
Okay. So we know that in the biology of appetite, once you improve one mechanism, there is something else that comes back to combat it. So the thinking is use combination therapy. So without using multiple medication, the way they develop the tirzepatide, it works on two receptors. So the GLP-1 receptor, which we knew all along since 2005, and we have medication that work on that, the Byetta, the Victoza, the Ozempic, the Wegovy, the Saxenda, all of those, they work on the GLP-1. Comes the tirzepatide or the Zepbound, it has an added bonus that it works on two receptors, one called GIP and one called GLP-1. The GIP is present in the fat cell, and the fat cell function is to store it when we eat and release it when we are fasting. So that is something unique, and there's also a GIP receptor in the brain in the hypothalamus. So it does enhance the effect of the GLP-1. So you have one compound that works on two different receptors, and you do get the complementary effect of them. So you tend to get a very powerful weight loss. The retaglutide that you mentioned is another improvement. So that's a triple agonist. So it will work on three different receptors, the GIP, the GLP-1, and now we have what's called the glucagon receptor. And we know that stimulating the glucagon might increase the blood sugar a little bit, but also will increase the burning of the fat and facilitate weight loss. So now we have the one agonist, which is the GLP-1, like the Wegovy or the Ozempic. We have the dual agonist, which is the Mounjaro or the Zepbound. And very soon, in the next couple of years, we're going to have the triple agonist. And the very early results looks fantastic as far as the weight loss. It's north of 20%, which is something really incredible. Just kind of put it in perspective, people who have bariatric surgery for weight loss, there are three of them. One called the laparoscopic band, and you lose anywhere between 15 to 20%. And now we have what's called the sleeve gastrectomy. You lose anywhere between 20 to 35%. And then you have the gastric bypass surgery, which is the more complicated one. You lose anywhere between 30 up to 45%. So now we have medical therapy that is approaching the 20% mark without the need for the surgery. So you do get the results of what the weight loss that you would expect from surgery without obviously going through the whole surgical procedure and anesthesia and the post-operative recovery and all of that.
And having your anatomy changed.
And having your anatomy change forever, and you have to be on some vitamin supplements for the rest of your life because you will not be able to absorb those vitamins if your anatomy change.
According to what you just explained, a great explanation, by the way. So we have medicines that affect one receptor. We have medication that affects two receptors, and there's one coming out that will affect three receptors. So I guess the first question is, because more is not always better, is everybody going to need to take the medication that has the three combo, or can most people get by with the one or two agonists?
So the answer is, anything north of 10% weight loss is actually a huge success, not only for weight loss, but it can actually add 5 years to your life free of complication. So not a bad return on investment. You lose 10% of your weight, you add 5 years to your life, and you keep the weight off as long as you stay in the medicine. Obviously, if there's a medicine that will give you 15% rather than 10%, everybody will ask for it. But it's always good to have different options because the tolerability of different medication is different and everybody is different. So some patients will tolerate one versus the other. So it's always good to have more than one option, and it's definitely add more to improvement of the overall health. Just kind of give you a little bit of a background. So we do not have any head-to-head comparison of one versus the other in the weight loss space. We do have comparison in the diabetes space, but since we're talking about obesity, you cannot really say that one medicine will give you more weight loss than the other because they were not compared head-to-head. But if you look at the clinical trial of the Zipbound, it's called the Surmount program. So there are 4 trials, 1, 2, 3, and 4. Surmount 1 was the biggest one, and it showed that the 5 milligram of the Zipbound will give you about 15% weight loss. 10 milligram of the Zipbound will give you about 19% weight loss. The highest dose of the 15 milligram will give you about 21.9, almost 22% weight loss. But the side effects of the higher dose is higher than the side effects of the lower dose. So not everybody has to go to the max dose. So you take whatever you can tolerate, and rest assured that the starting dose of the 5 milligram will give you 15% weight loss. Again, as long as you watch what you're eating and you're exercising and you live a healthy lifestyle. 15% weight loss is fantastic.
I totally agree. Now, it seems that they take these medications not just for diabetes, not just for obesity, but for prevention of heart disease. And it seems like eventually they're going to be recommending it for hypertension or any other condition that is worsened by obesity. So if you are someone who has a potential for heart disease or have had prior heart disease but are not obese, you're now getting prescriptions for these kinds of medicines. So are we going to get to the point where people are just going to suggest we put it in the water?
Well, the benefit of the medicine is very, very high, and it's obviously very much appreciated. However, from a heart disease standpoint, that SELECT trial was actually done in people who are overweight and obese. It was not done in lean people, so we do not really have any data if this benefit will apply to people with a normal, healthy weight. But we know that if you have a BMI or a body mass index of 27 or higher, and at least one other risk factor for heart disease and established history of heart disease, you do get the benefit. And that was the case with the study called the SELECT trial, that they looked at the effect of Wegovy. Or if your BMI is above 30 and you do have established history of heart disease or high risk for heart disease, there is benefit. Do we have any clinical trial or proof in lean people? The answer is not yet. So I don't think it will be in the water. But I guess if you have a BMI of 27 with multiple risk factors, or if you have a BMI above 30, you would qualify for those medicine and you will get the benefit of the weight loss as well as reduction of the future risk of heart disease.
Now, most of these medications are given by injection. Are there any medicines in this group that are oral?
Correct.
For people that
Yes.
are nervous about giving themselves a shot?
So for obesity treatment, not yet. The semaglutide is available in 3 forms. Injectable called Ozempic for diabetes and the Wegovy for treatment of weight loss. There is a oral formulation for treatment of diabetes. It's called Rybelsus. Rybelsus is only indicated for treatment of diabetes. So that oral form or the pill that you will need to take once a day is actually being studied for treatment of obesity, but it will be on a higher dose than the dose that is available for diabetes. There are two other compounds that are not on the market yet that are being investigated for treatment of obesity. And so far, the preliminary data showed 15% weight loss, which again is absolutely fantastic. So the answer to your question is we do not have any oral treatment of the GLP-1 class available at the present time. But I would imagine in the next 12 months, there will be 3 of them. The higher dose of the Rybelsus, once it's FDA approved, and there are 2 other medications that are being investigated that will be available, hopefully, in the next year or so. So by next year, we will have 3 oral options of the GLP-1 class available for treatment of obesity.
So let's talk about safety. How safe are these medications and what are the main side effects?
So the track record of the very first medicine that was developed in 2006, which is the Byetta, so from 2006 to 2024, we're talking about 16 years. There has not been any surprises. So the major side effects is mainly in the digestive tract. So one of the mechanism of those medication that when you take it, it will slow down the emptying of the stomach. So the food in the stomach will stay in the stomach for a longer period of time. So there are 3 major components of the food that we eat: carbohydrate, fat, and protein. Fat tend to have the longest retention time in the stomach. So if you have a big fatty meal, it stays in your stomach longer than, carbohydrate or protein. And that retention time in the stomach is what creates the side effects. It's mainly nausea. That is the most common one. So almost 25%, 1 out of 4 patients who take those medication will develop nausea. The other side effects could be vomiting, it could be abdominal pain, sometimes diarrhea, sometimes constipation. But the major one is the nausea. And the treatment to avoid that is to start low and titrate the dose very slowly. And all of the medication, they come in 3 to 5 different doses. So you do not start on the highest dose to avoid the side effects. So you start slow and work your way up. The second thing is we tell our patients try to avoid big fatty meal, which is basically what we have been saying for the past 200 years. But now there is a good reason not to have big fatty meal because you're going to get the nausea and it's a very uncomfortable feeling. The third thing which I learned from my patient is when they get the nausea, they will have a tall glass of ice water, and that kind of relieves the nausea. And if they wait 10-15 minutes, the nausea will go away. The fourth thing, which sometimes we use for patients who are really, really very sensitive to the side effects, is we give them nausea medicine for the first couple of months as we titrate the dose slowly until the nausea goes away. So 1 out of 4, that's 25% of the patient will get nausea. The people who discontinue the medicine because the nausea is so intolerable is less than 4%. So 25% will get the side effects, but only 4% will stop the medicine because the side effects are intolerable. Again, there's no medicine that is 100% tolerated, but 96% of the patients who take it, they stay on the medicine. That's actually a very good number.
Now, I like the way you put it. There were no surprises. So based on an understanding as a physician, based on the understanding of the physiology of how these drugs work, do you think there could be potentially long-term complications that we haven't thought of yet?
Well, after 16 years that the medicine have been on the market, we did not really see any abnormal signal. So I would say it is very unlikely, at least with the medication that we already have, that there will be any major problem down the road. One of the things I did not mention is a very rare kind of thyroid cancer. If I can just spend 1 minute explain to that, because there's a lot of confusion about it. So in any clinical trial, before the medicine is tried in human, it's usually tried on animals first. So the animals that they choose were rodents or rats. And to our surprise, it turned out that those rats, they have GLP-1 receptor on specific cells in their thyroid called the C cell. And when you use animal model, you do not use the human dose. You use a much higher dose. The dose that they actually used in the animal trial was 2 to 45-fold higher than the human dose. So it was a very, very high dose. And it turned out that those animals, they have almost 20% of their thyroid made of the C cell. So when you stimulate the C cell with a very, very high dose, they develop C cell tumor. And that was in rodents, in rats. So the FDA required that all of the clinical trial on those kind of medication, that they will pay attention and they will look for any kind of abnormal signal for C-cell tumors in human. And it was very, very rare. So C-cell in human, it's called medullary thyroid cancer. Medullary thyroid cancer, or MTC, represents less than 1% of all cases of thyroid cancer. And there is a very rare disease that is even more rare than the MTC. It's called MEN type 2, or multiple endocrine neoplasia type 2. That can happen. The cases in human attributed to those medications so far have not been there. So we do not really have any association. But because there was a signal in rodents, so the FDA have a warning in all of the medication of the GLP-1 class and say, if your patient or a first-degree family relative with history of medullary thyroid cancer or multiple endocrine neoplasia type 2, they should not be on that medicine. Sometimes patients will confuse and they read the label, but they don't read it clearly. And they say, oh, those medications cause thyroid cancer. That is not the case. 90% of the thyroid cancer are called papillary, 9% are called follicular, and 1% is others. So the two more popular thyroid cancer in human, papillary and follicular, have nothing to do with the GLP-1. So I just want to make it very clear that thyroid cancer is not a contraindication. It's only that very rare kind of thyroid cancer.
That particular one.
Correct.
That's great to know. So let's talk about convenience, because when you're talking about weight loss and all this being healthy, you talk about convenience. Now, I feel like these drugs may become convenience drugs. Everyone knows that obesity is not good for you. But now people who are not obese and don't have diabetes and really only want to lose 10 pounds are asking to take these medications. Oh, I just want to shake off 10 pounds. And then what happens? Do they have to stay on the medicine? Would you even use it for that purpose? And how long would they need to use it, if at all?
Well, I personally will not prescribe it for somebody who just want to lose 10 pounds and they are not overweight or obese and they do not meet the criteria for two reasons. Number one, you don't really need it. If you just make some adjustment of your eating habits and your lifestyle, you are going to get that 10-pound weight loss. Number two, as you know, those medications are in short supply because of the incredible demand. And I would imagine that incredible demand, a big portion of it is driven by people who should not be on the medicine in the first place. And the people who need the medicine badly, unfortunately, cannot find it. If the medicine is widely available, that's a different story. But, under the current circumstances, I don't think it is responsible that physician will prescribe medication for people who do not meet the criteria, while people who meet the criteria, they actually cannot get the medicine and cannot find it. So the answer is I probably will not prescribe it, and I would try to have a conversation with that person who would like to lose 10 pounds by just simply implementing very, very simple lifestyle changes and a little bit of exercise. And they don't have to be on a very restrictive meal plan, just something that is reasonable, and they can easily lose the weight and be very healthy.
And they can keep a food journal. They might be surprised.
I'll tell you something. That was a study that was done back in the late 80s, early 90s. They call it the most successful losers. So they actually, people who are losing the weight, they send them a survey every 3 months and they ask them to fill the survey. And they found people who lost more than 20 pounds for more than 2 years and kept the weight off, they have 5 habits. And the first habit is they keep a journal. The second habit is they watch what they eat and they prepare the food in advance. The third thing is they do 150 minutes of exercise per week. Number 4, they cut down their screen time, which is TV and all kind of gadgets, iPads and cell phone, to less than 2 hours a day. And number 5, they found that those people, they sleep anywhere between 7 to 8 hours. So the habit of the most successful losers, and by losers, I mean weight loss, that actually it's a good thing, is a journal, meal plan, exercise, limiting screen time, and good 7 to 8 hours of sleep. So you're absolutely right. Journal is one of the requirements for successful weight loss and weight maintenance.
So lifestyle modification is helpful for everyone.
Absolutely.
So the luxury gyms and Weight Watchers and everyone's getting into the act on these medications. How do you feel about virtual prescribers prescribing these drugs?
Again,
because that's happening a lot now.
That's very true. So if you have
you can see the advertisements for it.
I mean, since COVID, as you know, virtual medicine, thrives. So I remember during the 2 months when our office closed in February and March of 2020, we converted 100% of our practice to virtual practice. And our mission is make sure that the patient get their medicine and they do not run out of the medicine and they do not go to the hospital. And thank goodness we were actually very successful that we were able to keep most of our patients away from the hospital, and we were able to provide prescription refill and give them some kind of guidance during that, very, very tough time. And then it became very popular. So I personally would like to see the patient at least a couple of times in the clinic and just kind of see them face to face. And we usually do a body composition scan to figure out what is the percentage of weight loss and the muscle mass and the water weight. And for those patients who have a very busy lifestyle and they cannot come to the office, we can actually follow them virtually. But we usually require that they will come and see us at least a couple of times, kind of, get to know them and just do a physical exam and make sure there are no surprises. And if everything is okay, I think virtual follow-up is actually very, very reasonable. I know that some people are 100% virtual. I personally do not do that. But, for those patients who happen to live in a very far away place and, transportation is a challenge, I think virtual medicine is definitely very helpful.
I guess what I was referring to is some of the commercials I see. If you want to be on Ozempic, call this number and one of our providers will give you a consultation and provide the medication. So there isn't really a patient-physician relationship established there. People are just trying to get the prescriptions.
Yes, so that's why I usually like to use the chair analogy. So you have 4 legs of the chair. If you have 1 broken leg, you get by. If you have 2 broken legs, you're not going anywhere. So with those kind of clinic, you have 3 broken legs. So there's really very little counseling, if any, about meal plan, about healthy lifestyle, about exercise. The only thing you give is the medicine. So in all of the clinical trial that I cited, the medicine was used in addition to lifestyle changes. But if you use the medicine in vacuum, yes, you are going to get some weight loss, but you're not really going to reach the full potential of the medicine because the medicine only works when you use it, concert with the other 3 measures. Personally, I do not really support that practice. I really do not do that. So it's basically you're just going to a website and just give them the credit card and get the medicine and you're on your own. I don't really think that this is the best way, especially for those patients who happen to have any side effects. There's really nobody to supervise them and to manage them. In very rare occasion, on those patients who develop severe nausea, they can actually become dehydrated to the point that they can get what's called acute kidney injury. So those medications definitely need to be prescribed under the supervision of a physician. I'm not saying everybody will get this. Yeah, but you need to be monitored. Not just for the weight loss, but you need to monitor your kidney function. You need to monitor your body composition. So there's a lot of things that goes into weight loss other than the number that you get on the scale.
Yeah. Plus, the person who is giving the credit card and getting the medication may not even be the person that it's being given to. You know what I mean?
True. I mean, they will get the medicine and give it to their next door neighbor or friend. So who knows?
So the next question I have for you is, let's say someone loses, you said 15%, 20% of their body fat or their body weight. How long do they have to be on this medication? Is this like a lifelong investment here?
The answer is yes. The reason is if you take the medicine, you lose the weight, and you stop the medicine, you are going to gain most of the weight back. So there are actually 2 studies. One was done with the Zip-bound and one was done with the Wegovy. The Zip-bound trial, it's actually called the SURMOUNT-4. And what they did is they have the patients on the Zip-bound for 36 weeks and everybody lost an amazing 20% of their weight. And then they stopped the medicine and half continued the medicine and the other half stopped it. And they followed them for another year. People who continued the medicine for the second year, not only they kept the weight off, they end up losing another 5% on top of the 20%, a total of 25%. People who stop the medicine, they end up gaining about 14% of the 20% that they have lost in the first year. In the case of the Wegovy, it is called the Step 4 trial. So they tried the medicine for 20 weeks and everybody lost about 12% of their weight. And then they followed them for another year. People who continued the medicine, they lost another 8%, a total of 18.5%. And people who stopped the medicine, they gained 7% out of the 12 they lost. So whether it's Wegovy, whether it's Zepbound, if you take the medicine, you lose the weight. If you stay on the medicine, you keep the weight off. Once you come off the medicine, you gain most of the weight back, almost 1/3 to 1/2 of the weight regain in the first 6 months. So the answer is...
Even if you do the lifestyle modification.
Correct. So I like to use the blood pressure analogy. So you take a blood pressure medicine, your blood pressure drops. What happens if you stop the blood pressure medicine? It goes back up again. So the same thing with the weight loss medication. If you take it, you lose the weight. If you stop it, you gain the weight back. So is it a life sentence? For the time being, it seems that you need to stay on the medicine to maintain whatever weight you lost. And the benefit of that, even though the inconvenience of taking the medicine for a long term, that you do not gain the weight back. Because if you gain the weight back, your blood pressure will go up, your blood sugar will go up, your cholesterol will go up, your reflux disease will get worse, your sleep apnea will come back. And, you have to deal with all of those problems by adding like 3 or 4 other medicines. So my answer is, if you stay on the medicine, you are saving yourself 3 or 4 other medication that you might need to take if you stop the weight loss medicine.
Okay, so now you start the medicine, and obviously starting the medicine, you have to make that commitment to staying on it, as you just explained. What about the cost? These medications are incredibly expensive.
Very true.
How are people supposed to be able to be on a medication that can cost up to $1,600 a month without insurance?
If you are paying out of pocket, obviously nobody's going to pay, $1,200 or $1,100 a month for those medicine out of pocket, unless you are fortunate enough that you can afford it. I would probably say out of all the prescription that we write, for every 4 prescription that we write, 3 out of 4 are covered under the insurance. 1/3 or 1/4 of them are not covered, and we have to use other classes of medication that are less expensive. So is it covered across the board 100%? The answer is no. And I'm talking about patients who are commercially insured, because Medicare right now, they do not pay for any weight loss medicine. Because if they do, they will break the budget and they will not be able to sustain having Medicare any longer. So for those commercially insured, 3 out of 4 patients, they will be covered. Sometimes you need to do what's called a prior authorization. Some insurance company, they will require that the patient will be involved in a weight management program for at least 3 months before they approve the medicine. I have no problem with that. Eventually, the medicine will be approved and the patient will take it. So the cost will be the co-payment for the patient, which could be anywhere between $25 to $75. And both companies, they have vouchers and co-payment card that can bring the co-payment down a little bit to $25, which I think is very reasonable. But again, that medicine is very expensive. But if you do not stay on the medicine and you gain your 30, 40 pounds back, be prepared. You will be taking 2 diabetes medicine, 2 cholesterol medicine, 2 blood pressure medicine, a CPAP machine, something for the reflux disease, something for the arthritis, and all of those things will add up. So I'm not saying that, paying $1,100 is going to save your life for the rest of your life, but you do not have to pay that. Insurance usually will cover those medications 75% of the time, as long as the physician is writing it on label. On label is basically according to the FDA regulation. And both medication or all of the obesity medicine are indicated if you have a BMI or a body mass index above 30, or if you have a BMI of 27 with at least one what's called comorbidity or associated problem with obesity. Could be diabetes, could be hypertension, could be high cholesterol, could be obstructive sleep apnea, could be fatty liver disease. And unfortunately, most of our patients who suffer from excess weight, they have their fair share of other medical problems and they meet the criteria.
Now, you said that Medicare does not cover the medication. Do they cover it for diabetics?
They cover if you are diabetic, but that will be the diabetes brand of semaglutide and tirzepatide, but they do not cover the weight loss version of it.
So they'll pay for Trulicity and Ozempic. I saw that Costco had launched a weight program involving Ozempic prescription, and apparently it was $179 for a 3-month program. And then the person would talk to an online prescriber who then prescribes the Ozempic. And I thought, wow, that is pretty reasonable. But then I read the small print, and it says that if you don't have insurance, it will cost between $950 to $1,600 a month. The $179 does not include the cost of the medication. So I think they figure that just the fact that it's Costco, you think you're getting it cheaper. It's been very interesting talking with you, and you're extremely knowledgeable about these medications, which I'm very appreciative of, because I think that there's a lot of stuff online and patients don't have the opportunity to really get the real information and what's facts and what's fake facts and fake news. And, those are the problems that we have these days. So would you like to give us a little summary here?
So at the end of the day, obesity is a chronic disease that will require a long-term therapy. Like, think of it like high blood pressure or cholesterol or diabetes. If your blood pressure, your cholesterol, and your diabetes are under good control, it's not the end of the story. You still have to work as hard to maintain that. Same thing with obesity. So there are two phases. Number one, weight loss, and number two, the weight maintenance. And the weight loss, as we mentioned, 10% weight loss is a very, very successful weight loss, but you still have to work as hard to maintain that 10% and do not gain the 10 pounds back. And at the end of the day, it boils down to four simple concepts. Continue to watch what you're eating, continue to be active, combination of cardiovascular and resistance training, behavior change, keep track of what you're eating and prepare your food in advance. And number four, take the medicine and stay on the medicine as long as it is tolerated and no side effects.
But people still need to follow a healthy diet, even if they're taking the medication. Because I think people have the impression that they can just keep eating the way they're eating, do exactly what they're doing, no exercise, and the medication is going to magically make them lose weight.
Some people will lose the weight even if they are not careful, but those people are going to be very, very unlikely to maintain the weight. And they will find out the hard way. If they are not watching what they're eating, the weight will start to bounce back again. So that will be kind of the red flag and the motivation. So in our maintenance program, we ask our patients to come and see us every quarter, every 3 months or every 4 months if the time does not allow. But we usually tell them, you do have a red flag. If you gain 5% of your weight, do not wait for 3 months. And by that time, you will have gained all of the weight back. So that will be the time to call and ask for help. And we will be happy to see you and kind of restart or reset the button and start all over again.
Thank you so much, Dr. Yacoub. It's been a pleasure having you on the program. And I hope you come back some other time just to talk about weight loss in general, not just medications. Thank you so much.
Thank you. I would love to come back, and thank you very much for the invitation. I greatly appreciate it.
Bye-bye for now.
Bye.
Thank you for joining me on this edition of Wellness and Wisdom. Today, we had the pleasure of speaking with Dr. Tamer Yacoub, a board-certified endocrinologist and obesity medicine specialist. And we talked about the class of anti-obesity drugs called the GLP-1 agonists. Members of this class are Ozempic, Wegovy, Rybelsus, tirzepatide, which is also known as Mounjaro, and Zepbound. So I hope you learned a lot from just the background information that we sought to give you this morning. And remember, obesity has a multifactorial origin. It's environmental, social, cultural, behavioral, physiologic, and we didn't mention the genetic factors, but there are genetic factors as well. And so all of these need to be addressed if one is going to have long-term weight loss and maintenance. So remember Dr. Yacoub's analogy of the 4 legs of the chair. Make sure you take care of each of your legs. So the country is heading to a situation where 1 in 2 people is overweight. This is huge. Now, whether these medications are the solution to the problem, probably not, but they may be a solution, and you have to decide whether it is a solution that you want to investigate. So once again, thanks for joining me on Wellness and Wisdom. I look forward to seeing you on the next episode. And please give me a like or make a comment, and we'll talk to you soon. Bye for now.